Good morning to all our attendees to our 20th Viral Rheumatology Learning Series. I'd like to provide a few comments before I introduce our speaker, Dr. Rigby. I just wanted to remind everyone that we're using the chat function for general comments. We are using the raise your hand if you're having an issue with the platform or with the system. And we're using the Q&A or question and answer button really to post questions regarding the lecture content. Everyone can see your questions, by the way, in the chat and the Q&A, so obviously be professional. With that, I'd like to introduce Dr. William Rigby, who really needs no introduction. Dr. Rigby attended undergraduate at Columbia in New York and then attended Harvard Medical School. After Harvard, he joined the laboratory, Dr. Fanger, at Dartmouth and has been at Dartmouth since then, building a complex research translational laboratory focused on the idiopathogenesis of rheumatoid arthritis with particular interest on post-translational modification of CD40 ligand, which is a molecule that's still under study for certain diseases. Currently, he is vice chair and
Just lost.
Yeah. So
That's okay.
Just guide me.
yeah, Dr. Rigby, why don't you go ahead and start? I think we just lost Dr. Kamporis.
Okay, so I think I'll begin. I'll thank you, Dr. Kamporis. I hope I'm coming through loud and clear. Today I'm going to have the pleasure to talking to you about one of my favorite topics, and in particular I'm going to talk about the revelations and continued mysteries of RA pathogenesis. So in large part, this is a talk about what we don't know, and included in this talk are about 4 or 5 references that I hope you will remember and think about for the rest of your professional careers. Here are my disclosures. There's no off-label use. In fact, I'm not even talking about therapeutics. So what have we learned about rheumatoid arthritis pathogenesis and therapy in the last 50 years? That's my first bullet point. My second one is where, when, and how does rheumatoid arthritis begin following ACPA induction, that is the breaking of tolerance? And finally, what are the real challenges of the next 50 years in terms of how we think about rheumatoid arthritis and what do we need to learn? So I don't need to explain to this audience, but I will start to build a base on the concept of ACPA, anti-citrullinated protein antibodies. These are the single best serologic marker for rheumatoid arthritis. Remember that every arginine in the body can be converted to a citrulline by deamination, that is release of an NH3 group that's catalyzed by a family of enzymes called peptidyl arginine deaminases, also called PADDs. Now that post-translational modification occurs in every cell in the body, but it's not really relevant to rheumatoid arthritis. What is relevant to rheumatoid arthritis is the peculiar decision of the immune system to target that particular post-translational modification to make antibodies against it. The production of these antibodies, these ACPA, and we're going to be focusing on IgG ACPA. I can talk later about IgA ACPA in the lung, are tightly regulated and highly associated with the shared epitope, the HLA class II allele encoded by DRB1, and I'm going to talk more about that. If you, in recent series as well as in older series, excuse me, 80 to 90% of patients who have ACPA have the shared epitope. These antibodies of ACPA are to multiple citrullinated proteins, or CIT proteins. They can be to fibrinogen, alpha-enolase, vimentin, and many others. Now, in contrast to autoantibodies in lupus and other diseases where specific protein or RNA binding proteins like Rho and LAW are targeted, this array of antibodies to citrulinated proteins can be vast and involve many different epitopes on many different proteins. Furthermore, and this is one of the most interesting things, is that many of these autoantibodies are cross-reactive. and are low affinity. That is, they do not bind tightly. And we don't really understand whether it's the high affinity ones or the low affinity ones that make a difference in the reactivity, in the induction of rheumatoid arthritis. However, they are moderately sensitive and highly specific for rheumatoid arthritis. And the comment is made that they're rare in healthy individuals and in other conditions. But when we move on to the twin studies, I'll let you decide for yourselves. Now remember that smoking is associated with an increased risk of rheumatoid arthritis, but only the ACPA positive variant. And what I want you to do on these two bar graphs is first focus on the right side, the anti-CCP negative rheumatoid arthritis. And I only want you to focus on the purple, the magenta, and the yellow bars. Shown in the bottom left-hand corner of the right panel is that if you have no shared epitope, your relative risk for rheumatoid arthritis is 1. If you have 1 copy or 2 copies, your relative risk for rheumatoid arthritis is still 1. If you're a smoker, and that's in the yellow bars, please note that the smoking adds nothing to the development of CCP negative or ACPA negative rheumatoid arthritis. So ACPA negative rheumatoid arthritis is completely different from ACPA positive rheumatoid arthritis, shown on the left-hand side. Here, if you have no shared epitope and you're not a smoker in that magenta panel in the lower left-hand corner, your relative risk for rheumatoid arthritis is assigned a value of 1. As you acquire 1 copy, remember you can acquire the shared epitope from mom or dad. If you have 1 copy of the shared epitope, your risk goes up a little bit, and it goes up to about 4 or 5 if you have 2 copies. Now, please note in the yellow bars that if you are also a smoker and you have 1 or 2 copies of the shared epitope, your relative risk for CCP positive, ACPA positive rheumatoid arthritis goes up considerably. Excuse me. How does this happen? Well, I want you to take a step back and think about a hot dog bun. In this case, the hot dog bun is representing what the HLA-DR molecule looks like to a T cell receptor. So we're going to pretend the screen is an antigen-presenting cell, and it's got an alpha chain with HLA-DR alpha and HLA-DR beta at the bottom. And those are the elements of the bun. And in the middle of the bun lies a dog, or in this case, a pepperoni, some tubular-shaped structure or some structure that can fit into that groove. And you see that there's 5 amino acids listed on the bottom half of the HLA-DR beta chain, QKRAA. And those 5 amino acids are poking into the groove and influence how well that dog lays in the bun, or how well the pepperoni lays in the bun. And you have to have the pepperoni laying in the bun very tightly, or relatively tightly, for it to stay there and be perceived by your mouth if you're a T cell receptor, which is seeing the trimolecular complex of the alpha chain, the beta chain, as well as the peptide within. Remember, there are many different peptides that can lie in those grooves of the alpha chain and the beta chain. Shown here is a Corona beer and a Harpoon IPA. And so these are my representatives of native and non-native peptides that can bind and be found in those grooves. So if you're a T cell from somebody from Mexico, the hot dog on the left-hand side is a self protein, whereas the Harpoon IPA is a non-self protein, and so forth. Now, I'm now taking you from the hot dog bun to the structural diagram of the alpha chain and the beta chain and the peptide. And what I want you to note is that the QKRAA sequence are those 5 red arrows on the bottom right-hand chain, which show the 5 amino acids that poke into the groove and influence whether the peptide that's shown mostly in yellow can lie in that groove. What was not shown on in the hot dog bun, because it's buried by the peptide, is there's also an amino acid of valine 11, which is hydrophobic, which influences what peptides lie in that bun. And this is the sequence for HLA-DRB1-0401, the classic shared epitope allele. If we distill those 4 amino acids into valine at position 11, histidine at position 13, a lysine, remember, a basic amino acid at position 71, and an alanine at position 74, and alanine being a very small amino acid with no charge. You see that if you have those 4 amino acids in your chances of ACPA-positive rheumatoid arthritis relative to the general population is 4.44. If you switch the lysine at position 71 to arginine in the next line down, your risk, that is the sequence that's found, the amino acids that are found in 0404. And your relative odds ratio for rheumatoid arthritis is 4.22. However, if you change that valine in position 11 to a leucine, the odds ratio goes down to 2.17, consistent with a decreased ability, decreased association with rheumatoid arthritis. Now, these different peptides correlate to the ability of citrulated these different HLA alleles correlate to the ability of citrulated peptides to bind in the groove. And I'm going to show you that on the next slide. Now, shown on this slide is a log scale of the relative affinity of the MHC, that is the HLA-DR molecules at the alpha-beta chain, for either citrulated, is shown in white, or non-citrulated vimentin peptide. So in white is, in black is the vimentin peptide that we know that's associated with binding to HLA-DR. It's 65 to 77, so it's not very long. It's about 10 to 11, 12 amino acids. However, we also know that the arginine at position 70 gets citrulated. So that is shown in white. And so these two peptides differ solely in whether arginine 70 has been citrulated or not. If you look on the right-hand side, you see HLA alleles that are not associated with rheumatoid arthritis. It's 0301, 0701, 0802, 1101, 1302. None of those bind either the citrulated or non-citrulated vimentin peptide very well. On the left-hand side, if you look at the panel for 0101, 0401, 0404, you see that the citrulation of the vimentin peptide increases the affinity of binding by about somewhere between 10 and 100-fold. And anything less than 100 nanomolar is a high affinity binder. So the next question sort of is how does these citrulated peptides lead to, and the ability to be bound by the HLA-DR molecule, lead to the development of ACPA? And what I want you to think about is, what I want you to think about is on the left-hand side, I've created a sort of a faux antigen, faux organism, or a faux protein with 4 or 5 different epitopes that are there. And I want you to focus on the gold diamond epitope. If you have a B cell receptor, and this work was largely been piloted by Dr. Mark Mamula at Yale, you have a B cell receptor, meaning a surface immunoglobulin molecule that's got some affinity for that citrulated peptide, that citrulated post-translational modification. It will take that peptide in and then present it in the context of class 2 right here, and then it's being presented. And if it bumps into a T cell that's specific for that MHC peptide complex, citrulated, then it will activate CD40 ligand, which will activate CD40, CD80, 86 get activated, CD28 gets activated, the T cell activates and progressively provides help to the B cell. Now this is thought to occur in the lymph node, and the B cell, which has surface immunoglobulin, surface IgM, a low affinity molecule, then becomes progressively higher avidity and class switches to IgG, or it can class switch to IgA as the case may be. And this process is thought to be how citrulated peptides trigger the peptide restriction trigger the production of ACPA. Now, remember, most people who have the shared epitope don't make ACPA. And remember, the people that do make ACPA in their 30s, 40s, 50s, or 60s have had the components and the ability to make ACPA their entire lives, but something has changed. So when we think about rheumatoid arthritis, we have the genetics of rheumatoid arthritis that are associated with ACPA. They're HLA-DRB1. We have environment, we have smoking, we have gender, female, that's still not quite fully understood. And these three influences interact for the generation of ACPA. And many people say that they generate rheumatoid, they're responsible for the induction of rheumatoid arthritis. But I think all the data really is that they're important for the development of ACPA. And then in the current model system, we often think that, oh, we have ACPA, we're just on a fast train to getting synovitis. But the other questions I want you to think about is, remember, where are these ACPA occurring? These ACPA are occurring in patients with no symptoms, oftentimes no symptoms, and no signs or manifestations of rheumatoid arthritis. And then you have to ask, if they've been there for a long time, where were they induced, and why did they eventually cause joint inflammation? Now, the dirty little secret about ACPA is that they oftentimes don't progress, or they progress in very different ways. It's not a homogeneous manifestation of autoantibodies. So many patients, when they have ACPA, they don't develop, or many individuals have ACPA, as you will see in a subsequent slide, don't progress to rheumatoid arthritis. Some people progress to having palindromes. Palindromes are episodes of one or two joints swelling or extreme pain for a couple of days and then go away. And I have patients that have had, they're ACPA positive, that have had palindromes 3 to 4 times a year for 10 or 15 years and never progressed to rheumatoid arthritis. We have rheumatoid arthritis or synovitis that can present with interstitial lung disease. So it presents in 2 places at the same time. And about 1/3 of patients with interstitial lung disease and rheumatoid arthritis present concurrently with the development of arthritis. But we also have a significant patients in any interstitial lung disease clinic. We have patients with ACPA and no synovitis. So these are all kinds of, there's linkages back to the autoantibody, but saying that you understand how the autoantibody causes disease is not, I'm not sure you can say that with great confidence. So let's think about this a little bit more, because probably the most definitive way to talk about ACPA formation and talk about the genetics is asking yourself, how penetrant is the genotype? So if your mother had ACPA, or your brother or sister had an ACPA and they had rheumatoid arthritis, what would be your risk for developing rheumatoid arthritis? And there have been a whole bunch of studies done, but this is the study I want you to remember. And this was the Swedish twin cohort, which is a remarkable cohort, where they took 12,590 individuals, so over 6,000 twins, born before 1959. Of the twins, 350 of the 12,000 were found to be CCP2 or ACPA positive. Okay, so, and by the way, that percentage is approximately what it is in the general population in Sweden, around 1% ACPA positivity, or 3%. So what about the patients that were ACPA positive? Remember, this is sort of a cross-sectional study. Well, 103 were ACPA positive and had rheumatoid arthritis at baseline, so about 29.4%. Well, I was struck when I saw this paper, was that 70% had ACPA, but did not have rheumatoid arthritis. The other question that you have to ask yourself is, what was the concordance between twins? And what was interesting is that if you're a monozygotic twin, your concordance of ACPA between both twins, out of 75 pairs of monozygotic twins where one twin was positive, there was concordance in the other twin in only 3. If you looked at the patients who had ACPA positive rheumatoid arthritis, meaning those 103 that had ACPA positive rheumatoid arthritis at diagnosis, it was 1 out of 22. These are not big numbers. So so if we think about the twin studies, which we'll return to in a second, there's not a powerful signal there. Now, the other thing that was very interesting was if you looked at the same-sex dizygotic twins, so not identical twins, of the same-sex dizygotic twins, the concordance was 3 out of 111, as opposed to 3 out of 75 in monozygotic twins. So it was really not that different. If you're opposite-sex dizygotic twins, the associations were non-existent. And the same you can see is true for rheumatoid arthritis and ACPA-positive concordance. The same-sex dizygotic twins are maybe 1/2 as likely as the monozygotic twins, which is not making a great argument for a highly penetrant phenotype. So when I asked people to think about how penetrant is a genotype or driving the progression to rheumatoid arthritis, or first ACPA formation and then rheumatoid arthritis, the ACPA concordance was only 4%. And by the way, if ACPA was really powerful in driving the progression to rheumatoid arthritis, you would expect the concordance to be higher in the patients with rheumatoid arthritis. And the answer is there's really very little difference. So I think we're all left with a little bit, so we have to be all scratching our heads, and we have to also be asking ourselves, what does this mean in our own clinical practice? Not that we're seeing a lot of monozygotic twins. So this brings us to our second point: where, when, and how does rheumatoid arthritis begin following ACPA induction? So the paper that most of us all know about is the paper from the Colorado group and many other investigators in the Armed Forces cohort, where they looked backwards. Remember, in the Armed Forces cohort, you have serum collection over many years while you're in the military. If you look backward from when their rheumatoid arthritis developed to when they seroconverted, to when they first started making either rheumatoid factor in the top panel or ACPA in the bottom panel. And let's focus on ACPA. If you were diagnosed between 40 and 49, you seroconverted on average 8 years before the development of rheumatoid arthritis. If you develop rheumatoid arthritis between 20 and 29, you seroconverted on average around 3 years before the development of rheumatoid arthritis. Why the difference in age, I'm not really sure. But the point is that ACPA is not going to take you, the production of IgG ACPA in your serum does not take you on a fast train to developing rheumatoid arthritis. But this is also not relevant to how we really think about rheumatoid arthritis, because this is looking backward from a cohort that you already know about. It's not, you already know they develop rheumatoid arthritis. My slide froze. Somebody.
So,
Let's go back. We're almost there.
okay.
Okay, I don't know what happened, but okay. So now, not quite sure what happened there, but anyhow, we've got plenty of time. So instead of going backward from having rheumatoid arthritis, what does that patient who's got a positive ACPA in your office without symptoms predict? And you know, we've all seen these cases. The person with gout gets a positive ACPA and so forth, referred for something. And I want you to go back to that Swedish twin cohort in a follow-up study. They looked at these patients. Remember, there were 350 out of the 12,000 patients who had a positive ACPA at baseline. 103 had rheumatoid arthritis diagnosis at the time of the blood donation, and about 70%, 247, did not. And if you followed them over 3 years, 21 out of the 247 developed rheumatoid arthritis, 8.5%, which is not a big number if you're trying to come up with a treatment plan, because only 3% of your patients are converting over 3 years. So when we think about risk factors driving rheumatoid arthritis, we think about the genetics lead to the formation of ACPA. Our best understanding is that, and this is a work by Kevin Dean and among others, the group in Colorado has showed that ACPA formation begins as mucosal IgA responses, which then lead to systemic IgG responses that you can monitor in the serum. And then you develop over time, you progress through synovitis. But like I made my point earlier, you can not progress at all. And if over 3 years in that twin study, only 8.5% progressed to synovitis. So we have to conclude that serum ACPA, IgG appear, but the disease does not always follow. So the question sort of is, and the mystery sort of is risk factors that drive ACPA formation. What drives the progression to rheumatoid arthritis? What are the substantive factors? And then the other component of this is, should you treat a positive ACPA, knowing that there's a low level of progression? Now, obviously, these are issues that can be addressed and are actually currently being addressed in a multi-center clinical trial with hydroxychloroquine. So the next point I'm going to move on to is, so we have the ACPA. How does rheumatoid arthritis get from ACPA that's circulating in your bloodstream for 5 or 10 years or maybe even longer? How does it eventually lead to the development of ACPA-positive rheumatoid arthritis? And remember, the synovium is a relatively boring kind of backwater. One thing about the synovium we all recognize from gouty disease is that remember, there's no such thing as gouty pneumonitis. Is the joint is an inflammatory organ. It loves to get into a fight. It's ready looking. It has only one on or off switch. It's basically very powerful inflammation or not. And then you have to ask if, of all the synovial joints shown in the right-hand panel on this bone scan showing technetium pyrophosphate uptake and increased signal in specific joints, why is it in some joints and not others? And there's basically 3 models that we're going to talk about, we're going to consider. One model is the bone marrow process, where the process starts in the bone marrow and then moves out through the vascular channels in the bone marrow near the synovial joints and induces inflammation. And this explains why some patients have bone marrow edema when they're presenting with rheumatoid arthritis, but not necessarily a lot of synovitis. The second model is the model basically was championed by Nate Zweifler 40 or 50 years ago, where he called rheumatoid arthritis a disease of extravascular immune complexes, where ACPA are formed in the circulation and they circulate, and then what happens is that you presumably get trauma in a joint and then citrin-related proteins are emerged. The ACPA get access to what's otherwise a relatively non-vascular joint, and they induce immune complexes and inflammation. And finally, the last topic we're going to talk about is the enthesial or tendinous disease, which I think that's where the best data is. So the standard model about immune complex disease goes something like this. And we have the work done by Hani El Gabalawi in northern Manitoba to thank for this, with the First Nations folks who have a high incidence of rheumatoid arthritis, and that he's been studying for many years. And what they have, here's a 18-year-old woman, is asymptomatic at baseline in September of 2005. And her serum shows a positive IgA ACPA. She also had IgG ACPA, but we're just for this point, she was asymptomatic. Now, about 6 months, 8 months later, she gets arthralgia and has some knee pain. And a year later, she gets biopsy and started on hydroxychloroquine. Notice that her IgA ACPA has gone up a little bit. She's put on hydroxychloroquine and nonsteroidals, does well, gets pregnant. While she's being followed during her pregnancy, her ACPA titers continue to climb. And then when postpartum, her rheumatoid arthritis recurs. It goes into remission off drugs while she's pregnant. And then he restarts her on hydroxychloroquine and nonsteroidals. The idea that rheumatoid arthritis is an immune complex disease arises from the study, the biopsy that was done in September 2006. And the biopsy in September 2006 shows citrin-related antigens by immunoperoxidase staining in the synovium. Now, this is not a red-hot synovium, but there's clearly citrin-related antigens there. The second thing they did is they stained for IgG, C3, and fibrin. And remember, C3, IgG, IgA, and fibrin staining are now intensely deposited all in these tissues, arguing for that the citrin-related antigens are targets of immune complexes that have been deposited at this site. And this is sort of the model system for how rheumatoid arthritis gets going. Now, this doesn't really tell you that whether it really began in the joint, but it tells you that at the onset of symptoms, this is what you find. Now, I think a much more interesting study is the one that I'm going to describe that talks about the tendon or the emphysis as a necessary way station to getting into the joint. And then the question sort of is, how do you prove this? And I think this study done by George Schett's group was really slick. So in a remarkable tour de force, I have to, a lot of effort. They did random screening of 1,000 people for rheumatoid factor and anti-mutated citrulline vimentin antibody, the MCV assay, which is a very specific assay for rheumatoid arthritis. I mean, for ACPA. Of those 1,000 people, 12 were positive. Okay, so 1.2%, which is not that different. Of those 32 that were positive, they were referred, and of those 32 that were tested, 12 were CCP2 negative at repeat testing, or they had synovitis, in which case they had active rheumatoid arthritis. Of the remaining 20, they confirmed their autoantibody status by repeating their CCP2 and their citrulline antibody, citrulline vimentin antibodies, MCV testing. They also made sure that there was no evidence of arthritis. So if you had evidence of arthritis, joint swelling, they felt they took you out of the study. And then what they did is the remaining 20 people, they scanned and did high resolution MRI and CT scanning. Now, for those of you who are thinking about this approach, your first approach might be, oh, they're just going to pull up preclinical patients. And what I want to point out to you is that 5 of the 20 did develop rheumatoid arthritis at 2 years. And those 5 patients were characterized by morning stiffness, and they had tender joints but no swelling. But leaving those 20 in the group, let's look what the MRI data show. And look for osteitis. You found osteitis in 2 out of 13 healthy controls, 7 out of 20 of their ACPA positive patient population. It's really not a significant difference, but it's very small numbers. You can make it might be bigger if you have bigger numbers. If you look for erosions, 12 out of 20 had erosions in the ACPA positive group that were not appreciated, but 4 out of 13 of the healthy controls did as well. If you looked at synovitis, ACPA positive synovitis was seen in 13 out of 20 patients, as opposed to the healthy controls, 1 out of 20. And this obviously points to the superiority and sensitivity of the MRI to evaluating synovial swelling or synovitis, increased synovial intake. It doesn't mean synovial swelling, it just means increased vascularity. But the striking thing was the involvement of the tenosynovium at various sites in 16 out of 20 patients, 80%, and none of the healthy controls. So in other words, it looked like the synovium was the tendons and synovium were the areas of the most intense involvement that correlated with the presence of ACPA. Now, what's interesting, it was more in the proximal compartments, not in the distal compartments. So it was not necessarily back by the wrist. It was more in the palm of the hand and so forth. And what I want you to see is this is an MRI from this picture, from this study. The MRI shows that the white arrows show the intense inflammation in the dorsal interosseous muscles surrounding the flexor tendon that's running right through the middle of this. I think you can appreciate by looking at the left fifth and maybe the left fifth and the left first, that the MCP joints are totally spared and there's nothing going on there. So this person had an isolated inflammation of his dorsal interosseous muscles. Now, for those of you who have not thought about dorsal interosseous muscles, I just want to remind you that these are part of the intrinsic muscles of the hand. And what they are very important with is that and you can see where the tendons have been cut away, they're underneath the tendons. And they're very important for maintaining extension of the MCPs. When they get inflamed and tight, they constrict and the MCPs can no longer extend. So what you see in many of your patients with rheumatoid arthritis is that when they're flaring, oftentimes they have the loss of MCP extension And not just, this is oftentimes independent of whether they have joint inflammation or not. And that speaks to inflammation in the dorsal interosseous compartment. Said differently, I'm sure many of you have noticed that you have a patient comes into your office with rheumatoid arthritis, with no or presumed rheumatoid arthritis, and they have make a normal fist. They have no synovitis in their MCPs or their PIPs. They may have a little tenderness in their palm or in the palm, but they can make a normal fist, but they can't make a normal tuck. That is, they cannot oppose the distal pulp space of their finger to the base of their thumb, base of the metacarpal. And this is something that is a very striking finding. I would love, it's been relatively neglected, but I think it tells you a lot about the intrinsic muscles and possible interosseous involvement. So now, this is a study done in Germany. It was done in a way to evaluate, takes a large swath of patients and tried to identify asymptomatic seropositives and show the involvement of the tendons and enthesial pathways before the inflammation. But this has been done twice, and this has been confirmed in 2 other groups. This has been confirmed by the Mankia in the Leeds group, and this has also been confirmed in the Netherlands, where they took ACPA positive patients without rheumatoid arthritis by any criteria, and they looked at which patients progressed to developing rheumatoid arthritis. And what was striking was that the presence of inflammation or resident inflammation in the tendinous or enthesial places in the hand predicted the subsequent development of synovitis. So we've talked about RA pathogenesis. We've talked about where, when, and how rheumatoid arthritis begins following ACPA induction. And what I want to spend a few minutes on, I was talking about what are the challenges in the next 50 years. And one of the challenges is, do we really have hope of putting any way of predicting better therapeutic outcomes? And what I remind you all is the 3 old men walking on the beach were all a little bit deaf. And one says it's windy today, and the second guy says, no, it's Thursday. And the third guy says, thinking they said, I'm thirsty. So am I, let's have a beer. So what I want you to think about is that when you form ACPA, and the ACPA targets the joint, you actually have 3 different options on what's going to happen in that joint. We're going to talk a little bit about another major paper. And the major paper is going to talk about is the development. Then when synovitis does develop, it appears to be heterogeneous. That is, some patients develop what's called a lymphoid infiltrate in their synovium with B cells. Some people develop a mixed lymphoid myeloid infiltrate where there's more T cells and myeloid cells. And the third gets a less inflamed phenotype, which we call pauci-immune or fibroid. The names aren't important. And of course, it's been well recognized going back 20 or 30 years, if not longer, is that the synovium oftentimes exhibits germinal centers to make it like an ectopic lymph node, shown in the right-hand panel. And this was first described many, many years ago. And then oftentimes we see a myeloid phenotype where you see intense inflammation in the synovial lining layers with macrophage proliferation and synoviocyte proliferation, and intense subsynovial T cell infiltration in the below the synovial lining layers. Now, what about this? What do these signatures tell us? And the major paper that I want you to remember is this paper by Humby that came out in December of 2018. It was as an e-publication from the Pitsalis group, big multi-center study where they did biopsy on 129 patients with early rheumatoid arthritis. And they divided their groups. There's a lot in this paper to talk about. They divided their groups, as you look in the header at the top, of pauci-immune fibroid, diffuse myeloid, or lymphomyeloid. If you looked at the disease, their ages are not really that different. If you look at the disease duration, please note that the duration of disease is not that different, from 4.6 to 6 months. If you look at the SED rates, if you had pauci-immune fibroid histology, your SED rate was about 22, and your CRP was about 7.7 milligrams per liter. If you had fibroid, Both of those went up by significant amounts, 20 to 40%, or 50%. If you had lymphomyeloid in the far right-hand panel, you see that the SED rate was, mean SED rates were about 2 times as high as they were in the fibroid, and almost that much relative to diffuse myeloid. The same thing goes for the CRP, which goes from 7.7 in the fibroids to 13.3 to 28.4. And these are all statistically significant. And finally, when you look at the DAS28, which integrates the joint counts and the patient global as well as the SED rate, what you see is that the DASs go up as a function of the lymphomyeloid relative to the myeloid and fibroid. You look at joint space narrowing was also increased near the other blue arrow in the patient population that had lymphomyeloid disease relative to the other groups. And you can see this in other kinds of things. So lymphoid histology had an effect on clinical phenotype, and we have to understand this. And you can read the paper yourself, but it failed. It looks like methotrexate did not appear to have a selective advantage in one of these groups relative to another group. But it was there were trends. So the question I think we all have to ask ourselves is that we know about the haplotypes about rheumatoid arthritis. We know about the genetics. We know about the risk factors and the environment and gender. But what drives the histology? When the ACPA finally decides to trigger arthritis, does it drive different histologies? Does the histology that it drives vary as a function whether the disease starts as an immune complex or comes in through the entheses or tendons origins? And then finally, does this mean anything for therapy? And the Pathogenesis group and many people in Europe have been aggressively studying this. And I think we're going to probably have data on these studies coming out relatively soon. So I'm going to wrap up. Can progression from rheumatoid arthritis from ACPA positivity to synovitis be interrupted? Should we even try? The frequency of the transition is it a daunting task? Is it because it's so low? Apart from seropositivity, will any biomarker be defined? Clearly known that ACPA positivity predicts response to certain agents, whereas other agents work equally well in seropositives and seronegatives. And is a particular histology important? And finally, in the last slide, I want to tell you a story about the concept of drug-free remission. And the answer is, I'm going to give the answer away, is that I've had patients on methotrexate and infliximab for 20 years, stopped the infliximab because they got vascular disease or had a stroke or something, and kept them on methotrexate for 2 or 3 years. They never progressed. But then when I stopped the methotrexate, the rheumatoid arthritis came back 12 to 18 months later. So I've always had a healthy respect for the resiliency of seropositive rheumatoid arthritis. But I want to tell you one story that will I find even more amazing. So this is a patient named John, and John developed rheumatoid factor positive rheumatoid arthritis in 2005. He was put on methotrexate. He did beautifully. He went into remission. He was basically symptom-free. And then 7 years later, he develops a lymphoma, a follicular lymphoma. We stop the methotrexate. He stays in remission. But the lymphoma doesn't go away. We were hoping that it would go away with stopping the methotrexate. He gets B-cell depleted 6-7 times with rituximab. He gets rituximab, which was a typical treatment for follicular lymphomas back there. He gets rituximab plus an alkylating agent, bendamustine, for 5 cycles. He even gets a cycle of Zevalin, a radiopharmaceutical, anti-CD20. He then, because of progressive disease, he gets rituximab with CHOP, 5 cycles in 2013. And in 2014, he gets a bone marrow transplant from his 10/10 healthy brother, a healthy brother, and he gets a conditioning regimen. And 10 months after he develops his rheumatoid arthritis, 10 months after his bone marrow transplant, he develops rheumatoid arthritis. His symptoms come back. He's referred back to me. His ACPA is positive. His rheumatoid factor is positive. They're both in the 300s or high titer. But the thing that was so amazing is that he's got a low IgG. I think his IgG levels were about 100 milligrams per deciliter. So in other words, he recurred despite the fact that he had no B cells and so forth. And the other element is that this his bone marrow was 99.5 greater than 99.5% his brother's bone marrow. His brother doesn't have ACPA. His brother doesn't have rheumatoid arthritis. But our theory is that the ACPA and the plasma cells that persisted in his bone marrow, despite conditioning, despite being in remission for 10 years, and despite 11 cycles of rituximab, were still hiding out and still able to transfer disease. The interesting thing is that we gave him rituximab, which sounds heretical to somebody with a low IgG, and his ACPA disappeared. So what I want to share with you today is that rare events inform us, and I be happy to take any questions as they come up, and I will turn the podium over to Dr. Kampouris or Dr. Smith. Thank you so much for letting me talk with you today. And just in case you've never seen this, this is the green flash. The green flash is a rare event. As the sun dips below the horizon, a little pulsation lasting about a second of green light emerges under the right atmospheric conditions. And if you go around the world to westward-facing beaches, you'll always find a bar called the green flash. So thank you so much.
All right, thank you so much, Dr. Rigby, for a great presentation. We have a few questions from our audience, and the first one I'll get started with is there a correlation between the microbiome and periodontal flora and ACPA formation?
Is there a correlation? I think there is. I think there have been studies that have looked at this, and the question always is how is the microbiome influencing the persistence of or the induction of ACPA? And I think this has been a topic that's been discussed and chewed over, pardon my pun, chewed over a great deal. And I think Porphyromonas gingivalis is the one that's been thought about because it has some citrulline capacity. But the citrulline properties of Porphyromonas gingivalis are a little bit different. There have been some other bacteria that have been reported in the periodontal space that have been associated with citrinylation or hypercitrinylation, and these are all these are evolving stories, and I'm not sure that there's a clear etiology or definition problem. I think the better way to take it is to take a non-judgmental view of the data and just say that it looks like ACPA are induced at mucosal, in some way at mucosal surfaces.
Perfect. Another question that came up is, what is the role of synovial biopsy in our patients with rheumatoid arthritis, whether that be seronegative or seropositive patients, and can it help guide our choice of therapeutic agents?
Well, I think that's the $64,000 question right now. And those studies are ongoing. And I must confess, I've been very impressed by the work that's been crystallized, I think, by the lab of Pitsalis. But he's recruited many investigators all over the world, and including the United States. And I think we'll just have to wait and see how that plays out. It's going to be quite a challenge. I think is it going to predict? Because you have to put those up against whether ACPA levels or ACPA titers or other things make it different. But I think I'm always hopeful.
Great. Let's see if Photios is there. Photios, can you hear us?
Isaac, I'm here if you want me to chime in. I don't know if Photios has access. Can you guys hear me?
Yes.
This is Anisha. All right. Why don't you go ahead and ask the next question on the list, and then I will start talking.
Sounds great. Another question we had, is there a role of ACPA in other diseases? And I think specifically the question was in reference to psoriatic arthritis.
No, there's no role of ACPA. If you have a patient who's high titer ACPA positive, has got psoriasis, and and I've had a few of those with psoriatic arthritis. You still, in my experience, you treat them as ACPA positive rheumatoid arthritis, and everything gets better.
All right, and then so there was also a question. I know you talked a lot about ACPA positivity and sort of the different routes it can go. Some of it turning into real synovitis and true RA, and others with ILD. And they're doing the studies with hydroxychloroquine. How long do you think we should be monitoring these patients? Do we have them come in once a year and keep checking for stuff? Do we, maybe throw them on something? There was actually also a question even about rituximab in like early RA with positive ACPA without synovitis, just to try to prevent this antibody from forming. So any thoughts on those questions?
Well, let me take the easier question first, which is rituximab in early RA or seropositivity preventing the transition. That was basically a failed study that was done in the Netherlands called the Prairie Study. Now, if you're an optimist, you might look at it and say it worked, but it maybe delayed, one dose of rituximab delayed the progression of rheumatoid arthritis by about 10 or 12 months. And like I said, is that if you start looking at cross-sectional studies critically, you see that there's a very slow level of progression of rheumatoid arthritis, ACPA positivity to rheumatoid arthritis. So that I feel pretty comfortable about. And I don't feel comfortable about ACPA positivity in treating patients. I have to confess that when ACPA first came out on the horizon, I was getting all these referrals of patients without symptoms. I was reaching for the Plaquenil or 5 milligrams of prednisone after they failed non-steroid, if they had non-specific symptoms. I don't know what I was treating. Some people have stayed on those drugs. Many of them came off, and I'm following a group of people once a year. And then after about 3 or 4 years, we kind of stare at each other and say, what are we really doing here? And I say, call me when you have a problem.
Fair enough.
Another question that we had that came up was about the management of palindromic rheumatism. So how does the management differ in these ACPA positive patients with palindromic rheumatism, and when would you think about starting a DMARD, or which ones would you use?
Yeah, so that's a talk in itself, which I've given. But I'm going to tell you, palindromic rheumatism is an incredibly mysterious disease, and I recommend anybody who's interested in it go back to read the original descriptions by Hench, the same guy who developed cortisone that we all use and got the Nobel Prize. Palindromic rheumatism, some patients will respond to hydroxychloroquine, and they clearly respond to hydroxychloroquine. I have a graduate student, well, she's now a faculty member. I first started her on hydroxychloroquine, and she took it for 3 years, felt great, stopped it for 3 months, it came right back, did it again for another 3 years during her postdoc, and and now she stopped it again and flared. But I have other patients that just have episodes that just continue on by themselves, and I've tried 5 milligrams of prednisone, 10 milligrams of prednisone, Plaquenil, methotrexate, all kinds of combinations. And the question always is, how frequently you're having the episodes, and does that merit going to the higher level therapies? And I just have not done that, but maybe we'll find out that if you put somebody on a JAK inhibitor, or you give somebody an IL-6 inhibitor or rituximab or something, that would abate those. I just have not had a large enough series to do those studies.
Thanks, Dr. Rigby. Another question that came in is, I know we talked a lot about ACPA. So how do you have any ideas about how RA starts in the ACPA negative patients?
Oh, well, there's about 20 different ways it starts there. That's the reason why the genetics are so poor. So remember, first off, there's a Gaussian curve to polyarticular JRA or JIA. And I'm absolutely convinced that not just like adult Still's disease, I'm convinced that some of these patients who come in in their 20s and 30s or 40s with polyarticular arthritis, usually involving the wrists much more than the MCPs and PIPs, are just sort of the tail of adult versions of juvenile polyarticular arthritis, whatever that is. And there's also a lot of ANA positive polyarthropathy, and I'm never really sure what to call those patients. And sometimes I call them seronegative because that gets me access to various drugs. And and to tell you the truth, they usually do respond to those drugs. And and then there's other patients that you don't really understand why they're hot and bothered with the CRPs of 40 to 50, and classic exam, you would swear, I sometimes say what I've said to patients, this is going to be blood test positive rheumatoid arthritis. There's no doubt. I've never seen this. And then you repeat their ACPA, you get the ACPA is negative, the rheumatoid factor is negative, but their CRP is smoking hot. I have no idea what those are. Humility.
And I think another question from one of our panelists was actually, are there good animal models for ACPA?
No, they're terrible. There's one paper that showed that ACPA in a collagen-induced arthritis model, there's one paper that showed that ACPA administered sort of in an adjuvant way potentiated the arthritis. But most studies, there's not a really good model. And, we can ask ourselves why that is. For example, with ANCA-positive vasculitis, there's a pretty good animal model for MPO, but there's no good animal model for PR3. So there may be something structurally, maybe it's actually informative, but ACPA works so well, are so strongly associated in the adult and humans, but the mouse or other animal models don't work.
So another question, in terms of, and kind of more into treatment, so you've got your ACPA positive patients, and I know a lot of different companies will try to figure out, do they change the titer? And I know you talked about the 3 different types, like the lymphoid type and the fibrous type, and of different types of synovitis on a tissue level. Do you think there are certain biologics or targets that are more effective specifically for ACPA positive patients, or based on maybe their titer of ACPA?
Yeah, well, this is the argument that came out with TNF antagonists from Italy 10 or 15 years ago, which is that the high titer ACPAs did not respond very well to the TNF antagonists, and they responded better to rituximab. And then there's been studies done by Bristol Myers Squibb, which has a couple of different studies, which suggests that high titer ACPAs predict better responses to abatacept over adalimumab. How these work, I have no idea, but those studies are relatively strong. Having said that, one of the most interesting studies with rituximab was done by Genentech, which said they were looking at their patients with high titer ACPA who did not respond. And they found out the higher the level of plasmablasts circulating in the bloodstream, which you would think would predict rituximab B cell signatures and a high involvement of B cells and rituximab to work very well. Plasmablasts were actually negatively correlated. If you had plasmablasts circulating in your bloodstream, you didn't respond as well to rituximab. So I think it's going to be all, I think we have to prove it by proving it.
Thank you. I appreciate that. Photius, it looks like you're back.
Sorry about that. We had a power outage. And, I had one more question. In lupus, we noted that rituximab kind of resets the memory and naive population of B cells. Do you think that occurs in rheumatoid arthritis, and does that impact editing of those ACPA antibodies?
Absolutely not. It's one of the things I didn't talk about is just about the most fascinating thing about seropositive rheumatoid arthritis is that the body decides it wants to make ACPA all the time, morning, noon, and night. What will it do? It will not only take naive B cells and try to make them into ACPA responsive B cells, it will take memory B cells that were raised to certain other antigens, and then when those B cells go into the lymph node, they get repurposed to make ACPA antibodies. And one of the things that's really interesting is that why is the body trying to convert everything to making ACPA? So you're repurposing an already protective immune response. It's absolutely bizarre. The second thing that's been studied, and this was done by the Silverman lab, the first author, his name is Pelchak, P-E-L-Z-E-K, I think, a couple of years ago, was that if you treat people with TNF antagonists and you study what the effect on the circulating autoimmune B cells, meaning ACPA-bearing B cells, is that first off, before you treat them, the frequency of ACPA-bearing B cells is very high. It's like 10% of memory B cells. After you treat them, it's still 10%. In other words, you've not changed the basic orientation of the immune response for some reason, that want to expand its ACPA repertoire. It's very interesting. And I think in many ways it's completely different from lupus.
Right. So once in Rome, always in Rome.
Or Athens.
Thank you. With that, I'd like to wrap it up. I do want to remind the attendees to please fill out a survey that should come by tomorrow that will help us improve these for the future. And that, of course, as you may know, the ViRL lectures have touched over 50 countries and there's been over 1,900 registrants. So we want to thank all the speakers, moderators, panelists, and Dr. Dua, of course, who helped bring this to fruition. Thanks so much.
Thank you, guys. Thank you, Dr. Rigby. It was nice seeing you.
Thank you. Bye.
Take care.
Okay, great.